So it's increasingly clear that there's a wide variety of information that's collected about people within our cohorts, and that if we brought that information together from a wide variety of sources, we might get a better picture of what their exposure and their risk and their outcomes is. And so this is just a subset of a wide variety of information you might be interested in knowing about any single cohort participant. But we can get information from disease registries, claims data, electronic health records data, pharmacy data, wearable devices. We use administrative mortality data, labs, biomarkers, social determinants of health, and there's a wide variety of data sources that we could add to this picture of what each individual's life looks like. This is often thought about in terms of deep phenotyping on the omic side of things. There's similar digital phenotyping and a wide variety of exposome. So really understanding the diversity and the complexity of the environment and physiology of each individual. And in order to do that, we have to bring data from across different sources together to create this unique picture of each person. Importantly, though, when we're linking these diverse data resources to really expand our understanding of each cohort participant's phenotype, we have to consider a couple additional issues. And one is identifying and linking while protecting the privacy of that person. We can't be sending around that cohort participant's name and social security number to different places in order to link them. We also need to have a common ontology and really be concerned about data stewardship. So I'm going to just talk about one method that we use often to preserve privacy, and we use PPL, like a privacy protected linkage. And the advantages of privacy protected linkages are that one site, in this case, let's say site A, let's say this is a cohort and we want to link with electronic medical records, site B, we don't have to share our participants' information, and the hospital doesn't have to share the patient's information with each other. We may be at different sites, we may be across the country. What we can do is we can each identify that participant or patient's PPL number or hash ID, and then that hash ID is the only thing that gets shared with the linking center of site C. So that hash ID is unique in that if I put the same identifiers in, the same name, the same address, the same social security number, I will always get that same hash ID out. And there's more complexity to that, to be sure, but essentially that's the underlying concept. And so that if site A puts that same information in and site B puts that information in, they will both end up with the same hash ID. And that hash ID is privacy protecting, but it allows us to link across sites using a kind of honest broker in this linkage center. And then we can then strip all the identifiers out and link the data based on the hash ID, strip those out, and link by our study ID. And that allows us to preserve the privacy of our participants, as well as the privacy within their healthcare records, but allows us to identify a one-to-one linkage of a cohort participant with their electronic medical records. And these PPLs are used across a wide variety of settings, and increasingly they are allowing us to identify data for our participants without actually sharing any identifiable information. The next big concern is really having a common ontology or a shared data model. And so having a common ontology really means that we have a shared vocabulary or taxonomy of the data. And we're explicitly defining how these different data sources are related to each other. So what do I mean by that? Well, many of you may have heard of OMOP. So OMOP is a common data model, observational common data model, and it's often used in EHR records, but the same theory can be applied across a wide variety of data sources. So the OMOP common data model is designed to enable standardized analysis across different data modalities, really allowing for collaborative research and data sharing. So if everyone agrees on this common data model, then we have essentially kind of pre-harmonized our data and we can share it across data sources. An important part of the OMOP model as well is that there's a relationship across each of these variables. So we understand the visits are within the individual, who's within the provider, which is within the care site. So these structural relationships are preserved and very clear, and it can be expanded out much broader than EHR, but to understand when we're incorporating mobile platforms, when we're incorporating a wide variety of information from different sources, how they relate to each other and how they relate back to the study participants. One example of that we did a couple of years ago was really linking our cohort with a large electronic health record data set, which was called Healthlink. So it provided electronic medical records for individuals across the city of Chicago. About 3 million unique individuals were identified in Healthlink. And what we were interested in is pulling our MESA participants and understanding their healthcare encounters and their routine care within the electronic medical records. We do validate events, and we have medical records for events, but we didn't know anything about their routine encounters and their labs and their vitals from their outpatient visits. And so we linked the participants to the Healthlink, and you can see kind of the flow and all the issues that came up. Like I said, this was a couple years ago, and we're learning quickly about how to link these cohorts with electronic medical records. But I think it identifies some key considerations and really understanding the underlying sample. So not all of our MESA participants sought care within Healthlink hospitals. And then even within those, some of them didn't have all their labs and vitals. And so you can see we started to have to whittle away, and we looked at the reasons for those exclusions and how we could supplement them. But at the same time, we had to have this common ontology. We had to be able to say blood pressure in MESA is similar to blood pressure within the EHR system and how they related to each other over time. And lastly, I'll just end with the fact that with all of this data, both pooling and with unique data linkages, really the data stewardship becomes an important aspect of what our job is as researchers. There's a wide variety of information that's being collected on our diverse group of people across the world. And our concern as researchers really needs to be protecting and representing the concerns of others. So when we're pooling data across cohorts, we're very much concerned about the fact that we are doing this in a collaborative environment. We are representing the concerns of each of the cohorts, and it's done with their help and collaboration and their willing involvement. But I think even more importantly, it's also done with the participation of the individuals themselves, the participants, the patients. Our goal is to protect their confidentiality, to protect their data, and to really act with privacy and respect towards the information that they've willingly given us to pursue our research. And so that's where I'll end, and really that trust is given to us, and we need to live up to it in all that we do with data pooling.